Já estamos um pouquinho no avançado horário, então, meu nome é Gessé Lopes, sou oncologista clínico, pesquisador do INCA e também oncologista clínico do Grupo Oncoclínicas. Estou aqui para moderar uma mesa muito interessante, que é o cenário de pacientes com câncer de colo de útero metastático recorrente, o que temos de tratamento padrão. E para dar a primeira palestra, eu vou chamar o Dr. Michael Bookman, para ter uma fala sobre tratamento padrão e perspectivas futuras nesse cenário. O Dr. Bookman formou pelo Instituto de Tecnologia de Massachusetts, fez escola médica em Harvard, trabalhou em estreita colaboração com o GOG para apoiar a pesquisa clínica para mulheres com câncer ginecológico e como mentor de pesquisadores juniores. Bem-vindo.
Well, thank you very much. It's an honor to be part of this symposium as well as the session we had yesterday. And I know time is tight. I will try to be as quick as I can. So this is a photograph from ESMO 2023 in Madrid, where a lot of the studies that you already heard about were first presented in a large forum. And we'll come back to that. And I think it really leaves us with a lot of interesting options for our patients. But I'm going to go back a little bit further. And this is an example of platinum harvested here in Brazil, I'm sure. And it shows that there are differences between cisplatin and carboplatin, but the active group that does the damage to the DNA is the same once the leaving groups come off. Let's look up here, yeah. So, So the difference is the leaving groups, and that has consequences. So with carboplatin being organic here, there's a greater risk of allergy, but by and large, these molecules are pretty much the same because they're prodrugs and they're activated in the body to the active intermediates. Now, this was a study done a long time ago. Look at how much should the dose of cisplatin be in cervical cancer, because most of the prior experience was in other cancer types. And while people were thinking more is better, particularly in ovarian cancer, in cervix cancer, that was much less clear. It turned out also not to be true in ovarian cancer. But in this study, you can see that the overall results from 50 milligrams per meter squared compared to 100 were pretty much the same in terms of response rates and in terms of overall progression-free and survival. But it's interesting that historical data with cisplatin was actually much higher, claiming a 44% response rate in this setting. These responses were all uniformly less. So sometimes we learn things a little too quickly. We get preliminary data on a small number of patients. It does not always translate successfully into large-scale data that will guide clinical care. But as of today, we don't have evidence that dose intensity is important in cervical cancer with these drugs. So what about the other drugs, the non-platinums? Well, most of them are natural products, as you see here, and you'll recognize some of these. In particular of interest now with the antibody-drug conjugates are the camptothecins, which come from China originally, Camptotheca acuminata. And so this introduces different patterns of resistance. The patterns of platinum resistance in terms of DNA damage and repair and drug efflux and other things are very unique and specific to those classes of drugs, but with some overlap with PARP inhibitors, radiation, and other alkylating agents. The patterns of resistance with natural products is different from that because it's not about damaging DNA, it's more about getting the drug in where it's needed, and the cells have ways through P-glycoprotein and the multi-drug resistance proteins to push the drugs out and they can't get in, which is one of the major mechanisms of resistance. And then there are drugs that are not natural products and not platinum. And this is an example, gemcitabine being one. And it's a false nucleotide that gets incorporated into DNA, and then the cell cannot complete DNA replication and cell division. So it's kind of very different from all the drugs we talked about before, the patterns of resistance, the way it gets into cells and through phosphorylation pathways and so forth. And so it's attracted, this class of drugs has attracted some attention. So what do we view as the standard? Well, trying to look at gemcitabine and a newer drug, triapine, which is more specific for inhibiting ribonucleic reductase, this was evaluated by GOG in in patients with early stage cervical cancer as part of chemoradiation. And you see there was no difference in adding that in. So we've tried really hard to make our basic tools better. Like, what can we do that's better than surgery, cisplatin, carboplatin, radiation? And it's been hard to do that, and especially in early stage disease. So this had a lot of good science behind it, but it didn't work when it was put to the test in a randomized trial. Now, why are we left with cisplatin and paclitaxel or carboplatin as a standard? This was, again, an older GOG study looking at these 4 different combinations, trying to see could we do something better. And in fact, it showed that the DMC did an interim analysis, and it showed no likelihood that one arm was going to be superior to the others. And this is the data in terms of progression-free and overall survival. So you see, it appeared that cisplatin with paclitaxel was a little better, not a home run, but nothing else was approaching that, and they were all grouped together here on the progression-free and overall survival curves. So that's how we ended up with platinum and a taxane as the backbone of most of the treatments that we use today. Now, what about carboplatin and cisplatin? There's been an ongoing debate, as I mentioned earlier, about whether one is superior to the other. But cisplatin does have a history, particularly in germ cell tumors, of maybe being somewhat better than carboplatin. But some of those are artifactual results due to just different ways the drugs would dose because of the different ways that they're cleared, with carboplatin predominantly cleared through the kidneys. And that changes, obviously, the dosing paradigm. So we have data from a Japanese GOG trial that shows that really they're quite equivalent. And I think we need to wake up and understand this better, because we can really spare patients a lot of non-hematologic toxicity by using carboplatin instead of cisplatin. The only setting in their analysis of prognostic factors where cisplatin might have been better were in patients who had not had cisplatin before. But that was unbalanced because it was not a stratification factor in the trial. And I think it's a reasonable conclusion in most cases that carboplatin could be substituted, acknowledging that it might have more hematologic toxicity, but it certainly would minimize complications from non-hematologic issues, which are an important issue for our patients with cervical cancer, often have hydronephrosis or other problems that you want to be careful how you're treating those patients. So what about bevacizumab? Because that was the next thing to be added in. So this is from the experience in ovarian cancer. These are all the old phase 2 trials that were done with single drugs, looking at progression-free survival at 6 months, which was established as an endpoint to try to figure out if something merited further attention. This is an example with bevacizumab, giving it 15 milligrams per kilogram, standard dosing in ovarian cancer. And look at the progression-free survival for that given by itself without chemotherapy, single agent, and recurrent metastatic advanced ovarian cancer, both platinum sensitive and platinum resistance. And this was the survival data. So the important point was, here's a new agent, a biologic, targeting angiogenesis, and it was clearly better in terms of response rate and progression-free survival than all the chemotherapy drugs that were being developed at the time. And it appeared to work regardless of whether the tumor was sensitive to platinum or not. So another independent pathway that we can consider in trying to manage our patients. So this led to a whole bunch of trials in ovarian cancer, the vast majority positive for response rate and progression-free survival, but not improving overall survival in most cases. But what about cervical cancer? So here's the same historical data in cervical cancer and of all the chemotherapy drugs. And I've superimposed in yellow here the curve from bevacizumab. And you notice, maybe it's interesting, it's shifted the curve a little bit, but it's not the same result that was seen in ovarian cancer. And why is that? It's because cervical cancer is not the same as ovarian cancer. I think that there's less VEGF production in ovarian cancer. It's often very high, and ovarian cancer is one of the few diseases that really responds well to even bevacizumab as a single agent, which is not seen in most other cases. So we have to really understand the underlying biology of the tumors that we are treating to make sure that our patients get the best therapy. So the addition of bevacizumab to chemotherapy was evaluated in this trial, which I'm sure you're familiar with. And originally, this was more looking at the chemotherapy arms, because it was Taxol versus topotecan Taxol without platinum. But the DSMB reviewed the data, and there was no evidence of superiority for the non-platinum regimen. So it really became a trial of chemotherapy with or without bevacizumab. That became the key point to emerge from the study. And you see that the response rates, the progression-free survival hazard ratios, as well as the hazard ratios for overall survival, were significantly improved with the addition of bevacizumab. And these are the curves that back that up. And I think this led to approval in the United States, and that's been widely integrated into chemotherapy for women with advanced metastatic cervical cancer. So even though it's not as good in cervical cancer as it is in ovarian cancer, these are significant results. And the improvement in overall survival speaks not so much to the activity of bevacizumab, but the lack of other agents that can help patients with advanced metastatic disease. Because in ovarian cancer, patients can receive lots of other treatments, and it doesn't show up as much as a survival advantage when you do phase 3 trials. So the problem is that fistulas can form, and overall, going from only 2% without bevacizumab to 10% with. And why is that? And it's because of that anti-angiogenic effect on wound healing and the location of the tumor. But importantly, in this case, almost all of the cases were associated with prior radiation. And so radiation may, in fact, be a risk factor along with bevacizumab, and that's something to consider in individualizing treatment for patients. The other thing is that tumors of the cervix traditionally have very different responses depending whether they're outside of the pelvis, like in liver, lung, or other organs, or inside the pelvis, particularly if they're exposed to prior radiation. In fact, some of the older trials would exclude patients if the only disease they had was a tumor in the pelvis that was radiated, because the chance of that responding to treatment was very low. It appears that bevacizumab, one of the important properties that doesn't get talked about much, is that it can actually enhance response within tumors in the pelvis in patients with prior radiation. So it's a question of balancing these risks and benefits. And the way that it does that is by changing the tumor interstitial pressure, by improving the ability of drugs to get into tumors, improving the ability of these treatments to be effective. And bevacizumab definitely has that advantage, I think, that we need to consider in taking care of our patients, both pro and con. So the next step was we have carboplatin or cisplatin, paclitaxel, bevacizumab, then immunotherapy, of course. And you heard from the prior lectures in studying of more earlier stage disease what immunotherapy has accomplished, both alone and in combination with chemotherapy. So I'm not going to dwell on that too much, but I want to go back to 158, which was a large single-arm trial to validate data from an earlier phase 1 study. And you can see that the response rates overall, the first key point, 12%. So we talk about using immunotherapy all the time now in cervical cancer, but as a single agent, it was not that active. And I think that, and it almost wasn't further evaluated, because if you look, the response data seen here, it looks better when you look at the plot above, and these are some of these patients with long durations of responses. And this was comparable to what was seen in the phase 2, and it led to approval based on this large collective study. But if you go back to the phase 1, here's the historical data I showed you earlier with all the drugs that were tested. Here's the data with pembrolizumab. It really looks the same. And in fact, this would not even have been used further because of that if it wasn't for the fact that it was immunotherapy and it had a prolonged duration of effect. And so that was changed. I won't go through this trial because you've heard about that already today, but I just use it as an example because of the fact that these patients who responded better were patients who had more visible disease than patients without nodal disease or residual disease at the time of treatment. And I think that's a guiding point that might impact how we do things. Now, ESMO 2023 was important for a lot of reasons. One of our international colleagues, Isabel Rey-Coccard, was recognized as the ESMO award for that year. And it's unusual that a GYN oncology-focused investigator gets attention at some of these meetings. So that was very nice to see. And a lot of trials were presented there that have been talked about at this meeting, including including the Keynote A18 trial and so forth. But I'm going to skip ahead here to the BEAT trial because this has not been discussed as much. This is using platinum Taxol as baseline chemotherapy with atezolizumab and bevacizumab combination. And in that trial, achieved results that were pretty similar to what have been achieved with other immune checkpoint inhibitors. It doesn't clearly answer what the role of the bevacizumab is because that would have required a third arm, but it certainly provided a basis to be interested in this metastatic disease. Antibody-drug conjugates are a big news story. 200 of these are being developed. We have several that are widely used now in gynecologic malignancies, and they're bound to be changing the way we take care of our patients in the future. So I'm just going to close with a quick case that will make you think about this, put it all together. 45-year-old woman with high-grade squamous cell epithelial lesions and also adenocarcinoma in situ. And she had a small 8-millimeter tumor that was biopsied and was P16 positive, as you'd expect, increased Ki67, superficial invasion, and underwent radical hysterectomy with no other evidence of disease except for a 2-millimeter focus that was left behind. And she had no postoperative chemotherapy or radiation, did well for over 5 years. 6 years in, she had a discoid density in the lung, solitary lesion with retraction and thickening in the fissure spaces. And it was confirmed to be P16 positive. It had the molecular profile consistent with her prior cervical tumor, and it was also had a pathogenic mutation in KRAS and PDL1 CPS. So, yeah. So this is her CT and PET imaging. And so that's the lesion that was seen on X-ray. And then you can see that it does go down and extend almost to the liver capsule. So this is a solitary oligometastatic recurrence. It's going to set the stage for our next discussion. What would you do in this situation? Because it's pretty extensive, but solitary. Would you do radiation that's tumor-directed, or maybe do radiation to the entire chest, do surgery, chemotherapy with or without bevacizumab, without a checkpoint inhibitor? And would you do that as a neoadjuvant approach and then consider surgery to remove whatever residual disease remains? And there's reasons why there's a lot of interest in neoadjuvant therapy these days. So in conclusion, the management of metastatic recurrent cervical cancer has improved, but it does remain a challenge. This is a tough disease. There aren't that many active drugs, but our opportunities have expanded. But emergence of resistance is important to understand both for platinum, natural products, and other drugs. And it's a unique biology that's based on HPV driving the carcinogenesis, which is different than the type of mutations that drive many other gynecologic cancers. So multiple agents, as I've shown you, have roles in this setting. Combinations need more optimization for each patient, and it really should be individualized as much as possible. The impact of immunotherapy, we think, is going to be maximized in the setting of residual disease that will focus the immune response. It's hard to get an immune response if there's no antigen there to drive the immune response, in spite of blocking PD-1 or PD-L1. And then the antibody-drug conjugates clearly represent a major field of clinical development and establish efficacy as single agents, and we're going to wait to see what they might do in appropriate combinations with new studies. So I will conclude there. I'll tell you for my patient, we recommended a combined approach of chemotherapy, immunotherapy, bevacizumab, and then to be followed by surgery to remove whatever is left. The last comment on the slide. Thank you.